Hello, and welcome to an introduction to dry needling for chiropractic practice. My name is Dr. Aaron Wiegand. A little background behind me. I went to the University of Arizona, where I got my degree in physiological sciences. I've always been fascinated with how the body works, how it doesn't work, how to fix it, and also what does it mean by work? How do we measure these things? And not just do we have models for how the things that we do work, but that we show that they actually do work. And again, what do we mean by working? I went to Palmer West, received my certification in spinal trauma via the ICA and Dan Murphy. It's largely what I do today is manage cases after motor vehicle accidents and coordinating those cases with the med legal community. I found that dry needling has really helped in this arena immensely. I also got my certification in medical acupuncture as well as dry needling. I combine these techniques in my chiropractic practice, and I've been doing this for a while. Now, I also have a rich history in chiropractic. Here's my father at about 21 when you only had to do, I think, 3 years of chiropractic school after high school. So that's why he looks so young there. But I've been around chiropractic my whole life, and I think that dry needling can really, it has its place in chiropractic. Even if you're a traditionalist, it's something that you can integrate in what you're doing to really just augment what you're already accomplishing in your practice and for your patients. So how did I get into this? Well, one day I was doing too many or lifting too much at the gym, which I'm sure many of us can relate to. Unbeknownst to me, I had a tear in my in the annulus of my disc, which resulted in a 13 millimeter extrusion. You can see it there pressing against the PLL and forcing it into my spinal canal. Just felt great. But ultimately, I didn't know this at the time, obviously. And so my glute med decided to respond by going into a severe spasm. I could barely walk. And I ended up going across the street to the physical therapist that I was referring patients to. I was treating people for pretty much spine pain and health and wellness. However, I really wasn't comfortable treating a lot of extremities, and so I would send a lot of these patients over to the physical therapist. So I walk across the street, go to the physical therapist, and a young doctor of physical therapy says that he would like to take a 105 millimeter needle and stick it into my glute medius muscle and then use point stim to fatigue the muscle and then stretch it and get it functioning again. I was in so much pain I probably would have done anything. He could have said, to treat your pain, sir, we're going to have you put your head in this hungry lion's mouth. And I said, do you have the lion here? So after he was done, I had about 70% relief in my symptoms. And I was able to carry on with my day, which I was very excited about. But what I wasn't excited about was the fact that I didn't know what this was. Had never heard of it before, and I wanted to know more about it and whether or not chiropractors could include it in their practice. So for the next few years, I spent a lot of time with physical therapists, and Sue Falsone, who's a legend in the physical therapy community. She's the first female trainer in MLB history. And within the context of sports medicine, she trained me in dry needling along with other instructors. And I really found a deep respect for physical therapists, what they do, how they're a little different from us in many ways, but their passion for patient care is really just no different. And I was really inspired by spending a lot of time with them and learned a lot. But I also learned that there's a lot we could do and learn from them and integrate into our chiropractic practice in ways that's unique to our profession. So when I went back to my practice, I started integrating these techniques, which allowed me to really expand my scope, the things I was able to treat. Now I wasn't sending away those patients with extremity complaints. I had options for them. Also, I had something that could reduce pain that didn't require me to stretch or pull or adjust my patients who were in so much pain that those types of physical interventions weren't very well tolerated. And so I had something that I could help reduce their pain much faster and get them moving much faster, which we all know the sooner you can get your patient to move, the better and the faster the healing happens. It also made the office a lot more fun. Moving away from kind of the passive modalities of, say, traction or stim or heat or soft tissue, getting the patients to do more on their own really just created a more lively atmosphere in my practice. So why am I here? Well, number one, I want to set a standard for safety and quality for the profession so we don't lose this opportunity to competing professions. There's a lot of people doing dry needling, most notably doctors of physical therapy. And there's more of them than there are of us. I want to make sure that if chiropractors are going to get educated in dry needling, they do so in a way that really protects the patient, that minimizes risk as much as possible, and does so in a way that's the highest of quality. Also, needling techniques really opened up a whole new world as to just how I practiced in my office. It made it a lot more fun. I was able to treat a lot more types of conditions in a lot more diverse kind of way. And also, I have a saying, it's if you change your patient's life, they will change yours. And that's exactly what happened. I was able to do more for more people, and that really just changed my life and my enjoyment for what I was doing. Also, we go to school for a really long time. We go to school for years and years and years, studying many different subjects, and it really breaks my heart when I see this knowledge being relegated to what I see going on in most chiropractic practices. We know a lot, and to only be utilizing things like adjustments and soft tissue and stim over and over again, what we call cooking the patient, is really not the highest and best use of our knowledge. While all of these things, especially the adjustment, is highly impactful on our patient's health and the ability to help them regain function, it's not something that we could do so much more for our patients. And we know that integrating multiple techniques in any situation really increases the outcomes. And so dry needling is something where you really get to use your knowledge base to its fullest potential. So what we're going to be going over is, what is dry needling? What is it in the context of other needling techniques? Also, how does it work? What are the mechanisms we think that it works, and what's the data behind showing that it actually does work? Also, how is it different than acupuncture, and how would you use this in practice? I think that this presentation really is useful for anyone considering to add dry needling to their practice, and how you could do so within a chiropractic context, which is completely unique to how, say, a physical therapist might do it. So, dry needling in the context of other needling techniques. Well, the first and foremost, we have acupuncture. Traditional Chinese acupuncture is based in traditional Chinese medicine, which is based not on Western science or our current knowledge of anatomy and physiology, but rather philosophy, Confucianism and Taoism to be specific, theories such as yin and yang or qi. These were great explanations they used, really eloquent or elegant for the time, that they used to diagnose and explain how the body worked, how to treat it, and it's something that I think that everyone would do well to familiarize themselves with. But this is about 3,000 to 5,000 years old, and as we go with anything in science, the more we learn, things should change. So within traditional Chinese medicine, they have the 5-element theory. This is the basis by which they diagnose and treat. Each of these elements have a yin and yang component to them, and this informs them about where and how to apply needles. But eventually, acupuncture made its way to the Western world. A Dutch physician had seen acupuncture in Japan. He comes home, he writes a dissertation on it, and he starts using it to treat arthritis, pretty much disregarding the traditional Chinese aspects of the treatment, but more placing needles in the places of pain. I found this interesting because it seems as soon as acupuncture started heading west, immediately it was being used for musculoskeletal conditions. In the 19th century, it expanded to the English, the French, and the Germans. They start using it with electricity, but again, largely disregarding the traditional aspects of it. And in 1826, the Lancet endorses it, and it's still pretty much primarily used for musculoskeletal pain. But over time, it dies out. In the 1900s, early 1900s, it's not used. It's not kind of part of the medical landscape. Probably because medications are becoming more available, and that's kind of where medicine goes. And the people who perform acupuncture, it becomes relegated to those that use it in its traditional Chinese context, again, by way of meridians and points and qi. But then in 1960, this British doctor, Felix Mann, who sounds almost like a Bond villain, Felix Mann. I just thought it was a very strong doctor name for the time. Well, he takes acupuncture needles and he decides to start placing them way deep down. So he takes them all the way down to the articular pillars to treat neck pain, as well as upper limb pain, pelvic pain, etc. And he finds that tapping on the articular pillars and on the bones themselves was therapeutic for these patients. This is something called periosteal pecking, and we'll talk more about it a little bit later. Now, also at the time, we get Melzack and Wall's gate theory of pain, which we will also talk about later. But in short, this is the theory of pain by which the majority of what you're doing in your office is probably explained, in that non-painful afferents have the ability to reduce the perception of pain in the central nervous system. So how did it make it to the United States? Well, there's this fantastical tale about how in the 1970s, Richard Nixon wanted to open up relations with China, and so he sends a delegation. And along with this delegation comes a journalist from the New York Times. Now, the journalist comes down with an acute appendicitis, and in this version of the story, he has an emergency appendectomy where they use acupuncture instead of traditional anesthesia for the surgery. It sounds miraculous, but it's also not true. Not entirely, though. The journalist did, in fact, go to China. He did, in fact, have an appendectomy and an acute appendicitis, but they used xylocaine and benzocaine to anesthetize the body for the procedure. But they did use acupuncture for the post-surgical discomfort and pain, abdominal distension that he experienced, and he found relief in getting acupuncture. And he published his experience in the New York Times in 1971. And as a result, acupuncture kind of made its way into the United States. As time goes on, science kind of starts integrating with acupuncture, and we get what's called Western medical acupuncture. Western medical acupuncture is the application of acupuncture, but doing so based on science, physiology, and anatomy. Really, though, it tries to target nerves or create neuromodulation to attenuate the autonomic nervous system in a way to restore normal function and health. Now, if this sounds familiar, it's because it's largely the same model seen in traditional chiropractic, where practitioners will still work under the model of adjustments, change the tone of the autonomic nervous system, and therefore affect end organ function. So it's very similar to how many still practice acupuncture or practice chiropractic today. Now, Western medical acupuncture is not just performed by acupuncturists, but also physicians, chiropractors, and physical therapists, and it's seen throughout the Western world. Now, dry needling isn't just another evolution of acupuncture. What it is Janet Travell was performing trigger point injections on various patients, and by trying to find what the therapeutic benefit of the needle or the saline in and of itself was, they eliminated one at a time, finding that the hypodermic needle in and of itself was in itself effective. As things go on, time goes on, 1979, PubMed has its first study of using dry needling, but instead of using hypodermic needles, using acupuncture needles. So here's a study that tries to differentiate what's called dry needling and deep acupuncture. It's a study where they compared superficial needling versus deep needling in the efficacy of treating back pain. The differentiation that they try to make is that dry needling focuses on trigger points, while acupuncture focuses on something called ashi points or traditional acupoints. But when we line up traditional acupuncture points with where we typically find the painful spots in, say, fibromyalgia or trigger points, we find that the overlap is 93.3%. So largely, these points are the same. In fact, most acupuncture points started out as ashi points, and largely, they're just the same thing. So there's really no difference there. Now, also, acupuncture points tend to overlie deeper structures that we all treat. For example, BL52 overlies the quadratus lumborum, or the HTJ points, or Junta Jichao, which I'm sure I'm mispronouncing, overlies, if you go deep enough, the multifidus. Yao Yan targets or if you were to go deep into the Yao Yan point, you're going to target the cluneal nerves or superior cluneal nerves. These are nerves that we treat all the time in pain management. They can become extremely painful, but they're largely cutaneous nerves. And also, GB30 perfectly aligns typically over the piriformis. Now, that being said, just because you know where these points may lie doesn't mean that you could safely needle them deeper without a better understanding or three-dimensional understanding of the anatomy involved. The quadratus lumborum is very thin, and just beyond it is the kidneys. The piriformis point, that's a great point if you want to needle the piriformis, but it's also a great point if you want to put a needle in the sciatic nerve, which your patient probably wouldn't appreciate very much. And there are specific techniques to know what depths are safe and which ones are most tolerated by patients so you don't cause any harm. And that requires additional training. So here's a little bit, I made this grid of the 4 different types of needling techniques, where you have traditional acupuncture at the top, which is based on traditional Chinese medicine. Its scope is to treat everything and anything, but it does so by targeting what's called qi. Medical acupuncture is based on modern anatomy and physiology. It targets, again, its scope is everything, and also traditionally uses the acupuncture points. Deep acupuncture really focuses on neuromusculoskeletal conditions, but again, they tend to stick to acupuncture points. Dry needling, on the other hand, is also based in anatomy and physiology. It treats neuromusculoskeletal conditions, but its target is the tissue itself, the nerves, the muscle, and the fascia. So while there isn't a whole lot of difference between acupuncture, deep acupuncture, and dry needling, 1 or 2 major differences is that traditionally deep acupuncture uses needle winding, which is something that almost every acupuncturist uses. It's where you place a needle in situ and then proceed with winding it. You'll notice a tissue grab, or you notice a tension around the needle, and when you pull on the needle gently, you'll create this dull, achy sensation called the da shi. Now, this is found to be therapeutic. However, you're going to typically leave those needles in place for 15 to 30 minutes. Where in dry needling, all of that is true. However, not only do we perform winding in dry needling, but also pistoning, where, say, you take the needle and draw it in and out of the tissue in a type of fan-like pattern, or pecking, or periosteal pecking, where you peck on the bone itself, kind of creating a bleeding sensation or bleeding effect of the periosteum, and also a unique way to reduce pain there neurologically by some unique mechanisms there. But you can also perform dry needling within a matter of seconds, while you can leave them in place for longer periods. For example, you could needle the upper trapezius muscle in a matter of seconds by pinching the muscle, taking the needle, drawing it in and out in the trigger point, and then releasing it, and be done with the therapeutic intervention. So dry needling and deep acupuncture are largely the same thing, with some very small differences. And really, your body doesn't know what you're calling it. But these are things described in literature as trying to be 2 distinct different things. So if you were to put them all on a chart, on the left, you have traditional Chinese medicine, which is the basis for traditional acupuncture. And under science, you have Western medical acupuncture and deep acupuncture, which is based in science, kind of evolved from one another. And then dry needling, which again has its own origin story, being born out of using hypodermic needles. Travell and Simmons, as far as we know, weren't thinking about acupuncture at the time when they developed this technique, and it kind of started out of its own thing. So if you look at the literature on these techniques, and you do a search within PubMed, you can see that acupuncture produces a little over 41,000 results. Dry needling 981, and deep acupuncture has 33. Now, that being said, the body doesn't really know what you're calling it when you place a needle into various tissues. The therapeutic effect isn't dependent on what they labeled the intervention on the report. However, what's great about all this is that this is a wealth of knowledge that can be used by all needling practitioners to help improve and better understand the outcomes that they get with their patients. Another startling discovery that I made while doing this type of work is that within a year, we went from 615 dry needling citations to 926. So the physical therapy community and the medical community are studying this heavily, and it's becoming more and more recognized into the mainstream. Interestingly enough, the vast majority of people who do seek out needling techniques or acupuncture do so for musculoskeletal reasons. Nearly 40% of the people seeking out acupuncture do so for musculoskeletal complaints. In the United States, these are all the states in blue where doctors of physical therapy can perform dry needling. The red is where it's prohibited, and the gray is where there's no specific language within their Practice Act. I put this up here because this is something that's happening everywhere within the United States. Your patients already know about dry needling. Probably. Physical therapists are getting certified in droves to perform this technique because of its efficacy and popularity. At any given weekend, I estimate 200 doctors of physical therapy in the United States are being certified to perform this technique just any given weekend. Now, within the United States, you have the states here in orange are the ones where chiropractors are permitted to perform dry needling, and red is where it's prohibited, and the gray is where there's no opinion as of yet. Now, that being said, each of these states has unique qualifications for performing dry needling, and some are much more difficult than others. In my home state of Arizona, for example, one needs 24 hours of dry needling education, which must include some sort of bloodborne disease education. In Texas, there is no minimum hour requirement as of right now, as of this recording. And then certain other states will have 150 hours or 50 hours. It just depends on where the state is and what's mandated to get these certifications. So it's highly variable. So I thought this study summed up dry needling very well. They said it's minimally invasive, which is true relative to, let's say, comparing it to other interventions for the same conditions. They say it's cheap or it's less expensive than, again, comparing it to other interventions. It's easy to learn, which is absolutely true, as long as you have your background in anatomy and physiology ahead of time. And it's really easy to, and you can do it relatively safely, but you have to have the appropriate training. With deeper needles comes greater risk, and it's important to undergo the proper education before embarking on any new intervention like this, which inherently carries more risk than not performing it, and typically more risk than what most chiropractors would perform in their office. In this study, they were trying to find the effect of trigger point injections, which is something we do commonly in pain management. They found that the therapeutic effect of the trigger point injection was largely due to the needle or placebo rather than the injection or the saline or any kind of active drug. Now, I'll tell you from firsthand experience, I've watched nurse practitioners undergo training in trigger point injections in a matter of maybe an hour before performing them on patients. I don't know if this is the norm. It is only my experience, but it's openly discussed that the therapeutic benefit of the trigger point injection is the needle itself, and not so much how much medication or whether any medication is applied to the treatment at all. So here's a study where they looked at patients suffering from greater trochanter pain syndrome. These are largely your patients with, say, trochanteric bursitis or glute tendinitis, and they found that they got similar results if they used dry needling or if they used a corticosteroid injection. Here's another study comparing dry needling to the effects of cortisone, Botox, and platelet-rich plasma. Again, they found that they were getting similar effects on pain and disability. Now, dry needling is considerably less expensive. It utilizes significantly less risk, and it's much greater tolerated by the patient. In fact, they go on to say that when you compare dry needling to platelet-rich plasma, dry needling may produce better long-term outcomes than cortisone injections as well. So not only are these treatments similarly effective, but the effect of them on the conditions that are being treated is longer lasting. So in this study that compared superficial needling versus deep, they defined superficial needling as anything below 10 millimeters and anything deep as anything more than 10 millimeters. And what they found was that the deeper needles just got a better outcome than the superficial ones when comparing it in its efficacy in treating pain. In another study that studied patients suffering from myofascial shoulder pain, they found that they defined superficial as 4 millimeters and deep as 25 millimeters. They left the needles in place for 20 minutes and they wound them every 5 minutes, so for about 4 times. These are the points that they used, and then they compared pain outcomes on the McGill Pain Questionnaire. And what they found was that deep acupuncture was just more effective than superficial, and they attributed that greater efficacy to the importance of muscular afferencies. So what are we talking about here? Well, the reason why deeper acupuncture tends to get better results, and by better I mean lower pain, longer lasting relief, and also less disability, is because dose matters. Now, when we place a needle into the patient, the first thing we're stimulating are mechanoreceptors within the dermis. However, if you go deeper, you're going to stimulate the mechanoreceptors within the muscle. So when you're performing traditional acupuncture, typically you're able to stimulate free nerve endings, the Merkel discs, the Meissner corpuscles, the Ruffini's, all these mechanoreceptors that give us a sensation of different types of touch. Whereas when you go deeper, you're influencing the mechanoreceptors. And as we know, mechanoreception is a huge source of afferentation to the central nervous system. So how does this have to do with pain? Well, Melzack and Wall's theory, pain gate theory, says that mechanoreception follows along what are called thick A beta nerve fibers. These are the heavily myelinated, very fast axons that carry mechanoreceptive information to the central nervous system, whereas pain travels along thin A delta and C nerve fibers. While they both synapse at this location in the dorsal horn called lamina 2 or substantia gelatinosa, what happens is essentially the thick A beta nerve fibers will spray enkephalins onto the C pain fibers and stop them or reduce their ability to transmit that pain or nociception to the central nervous system where it can be perceived. But it's not just neurological. Also, you're creating tissue damage, and when you do so, there are these histological effects that change the sensitivity or modulate the sensitivity of pain nerve endings, such as mast cells and macrophages. These things release cytokines, which change the sensitivity of the nerve ending. It might explain one of the effects of how that dull, achy sensation that seems to produce better outcomes when we wind the needle, how that actually works. That dull achiness may be the result of these cytokines and producing those superior pain outcomes. So dose considerations, what does it mean? How do you add or reduce dose other than going just deeper? Well, one is gauge. The fatter the needle or the greater the diameter of the needle, the more mechanoreception and stimulation you're going to create. Now, also, it's going to be more painful, which is why we use acupuncture needles and not hypodermic needles. Hypodermic needles are considerably more painful because they're thicker than acupuncture needles. The number of needles we use is going to increase the amount of dose or the amount of mechanoreceptive afferentation that we're implementing into the treatment. The amount of needle manipulation. If you leave a needle in place, that's one thing. But if you start to wind it, if you start to fan it, or start to piston it, or any of these other techniques, you're adding greater amounts of mechanoreceptive input and therefore greater dose. You can also add stimulation or e-stim to the needles. Rather than using, say, a pad to transmit TENS to the area, you can use the needle as a conduit and send the current down to the deeper structures that we're trying to target directly. And that stimulation definitely and dramatically increases the amount of mechanoreceptive input that we're putting into the central nervous system. Time, how long you're leaving it in place, and again, depth matters. Now, while the greater the dose, the greater the input, this isn't always well tolerated by the patients, and we'll talk about that a little bit later, but we want it to be as comfortable as possible, and we don't want to create unnecessary pain. And so in some patients, especially when they're first starting out with this treatment, you may use a lower number of needles, or perform less manipulation, or perform it for less time, or you won't be able to add stim right away. So these are all ways you can kind of stair-step your dose with your patients. So here's a literature review that just found that adding dry needling to traditional physical therapy to plantar fasciitis would just produced better outcomes. So not only the things that we do, exercises and manual therapy and ultrasound, these things are all effective in treating plantar fasciitis, but adding dry needling was just significantly more effective. This is another study that looked at dry needling for the treatment of tension headache versus a sham, and they found that not only did it effectively treat the tension headache, but also increased health-related quality of life. Reducing pain does improve people's health and their quality of life. There's no necessity to extrapolate pain from improving somebody's health. By reducing pain, we are able to dramatically improve the quality of people's life and the function of their body as a whole. Here's another study using dry needling, suggesting that dry needling should be used in the treatment of headache, either alone or in combination with other pharmacological treatments. Now, working in pain management, I work with many patients who have a lot of times already been to chiropractic care or physical therapy, and it simply isn't getting the effects that they want. And so they will come to pain management, which is largely pharmacological intervention. However, using physical medicine in conjunction concomitantly with pharmacological treatments can be a benefit and or reduce their reliance on these pharmacological treatments, which is an outcome I think we can all appreciate. We want our patients to use no drugs if necessary, but less is definitely better than not having an effect at all. There's a common saying, don't let the perfect be the enemy of the good. And if you can reduce someone's reliance on medications, that's a good thing. Here's another study comparing traditional physical therapy and dry needling. If you add dry needling to people suffering from back pain as a result of disc herniations, these are people that walk into chiropractors' offices all the time, and they found once again that dry needling had an additive impact and that the improvement lasted for at least 2 months. Here's where another study was looking at dry needling and treating neck pain. They said that the combination of dry needling was effective, or was a positive effect when comparing it to the traditional interventions on not just improving pain, but pain-related disability, pain pressure thresholds, and cervical range of motion. So not only is it about pain, but the function of the patient. They're able to move more, have more function, but also their pain pressure thresholds improve. So that means their nervous system's ability to modulate their own pain improved as well. So for example, if you're going to, we've all had those patients where you barely touch them and they hurt, and that's kind of just everywhere. But you can actually change the nervous system's perception or thresholds for pain by effectively treating these conditions, and you can do so with dry needling. Here's a literature review on treating patellofemoral pain using trigger point therapy, but they're not actually they're not needling the patella itself. They were using dry needling at the glute medius and the quadratus lumborum muscles to change the biomechanics of the patient, correct the biomechanics of the patient. A lot of times patellofemoral tracking problems as a result of weak or glute medius and QL that just aren't firing like they should, resulting in this kind of angular pull on the patella. And so it's not just about treating the area, but you can also treat the cause of these kinematic dysfunction as well. This was a study using dry needling with stim on osteoarthritis. They also used a technique called periosteal pecking, which we've talked about, where you use a needle to stipple the periosteum tissue. And they found that these patients were 1.7 times more likely to have completely stopped taking medication for their pain at 3 months than individuals just receiving kind of traditional physiotherapy. So how does dry needling reduce pain neurologically? Well, locally, we have the gate theory of pain, which we've talked about. You stimulate mechanoreceptors, and this can kind of segmentally and locally reduce the perception of pain. But also, over time, or with more input, you can centrally reduce pain via mechanisms essentially by stimulating paraqueductal gray and raphe magnus, which are in the brain, and they have collaterals that go all the way down the spinal cord and synapse on every dorsal horn, and reduce pain that way via endogenous endorphins, enkephalins, serotonins, and so on. So it's not just about the segmental reduction of pain, but kind of a general ability of the central nervous system to accurately modulate pain as well, or effectively modulate pain. So how does it reduce pain in, let's say, myofascial pain specifically? Well, this is where we get into trigger points. By taking a needle and placing it into the muscle, you're introducing oxygen or more blood flow and circulation in the area. So to a muscle that's hypoxic, this is a good thing because now you can restore normal metabolism and therefore electrical activity within the muscle. This is really note also that local twitch responses tend to have or produce a better outcome than if you don't elicit one. Now, this is something that isn't fully agreed upon. You can get it's almost like an adjustment. Do you need to hear the cavitation for it to be an effective adjustment or not? The literature suggests no. And in dry needling, we're not exactly sure if the twitch response is necessary or not. However, it's interesting to talk about the physiology behind the twitch response, more so that by introducing oxygen, if you think about a trigger point, there's an accumulation of acetylcholine, you're introducing oxygen, and therefore the uptake of acetylcholine can then go underway, and it results in the muscle quickly twitching from all that acetylcholine that's floating in the area. So let's get into that a little more deeper. The other thing that dry needling does is it promotes angiogenesis. So by essentially poking holes in the meat and creating more circulation, there's going to be growth of capillaries to the area where now that muscle and that tissue is going to get a better feed or perfusion of nutrients over time with the integration of these techniques. Here's an example of circulation being improved neurologically via dry needling, where they needled a trigger point in the glute medius muscle and found a dramatic change in the perfusion of the lower limb as far as circulation was concerned. Now, theoretically, this would be because of somatovisceral reflexes, where the pain or maybe even the nociception going to the central nervous system or at the segmental level into the spinal cord is resulting in an increase in tone or activity at the IML or intermediolateral cell column, resulting in more sympathetic tone, which means more vasoconstriction to the affected body part. And by reducing this input of pain to that area, we're restoring normal autonomic tone, and that's resulting in a dramatic increase in circulation to the lower extremity. I felt this was a pretty impressive study. So let's talk about the importance of trigger points. So we often think of trigger points as these muscle knots. However, that being said, we haven't really ever dissected out a trigger point, to my knowledge. We have all these theories about how they work and what they are, but we simply can't measure the physiological impact of those. And also, there's very poor inter and inter-examiner reliability to find these things. It's not unlike the subluxation. We have all these theories about how they work and the impacts they have on health and physiology, but we struggle to really to basically take a picture of it or demonstrate it in real life. So when it comes to trigger points, we realize a lot of this is theoretical, and ultimately we just know that what we find are these painful points in patients where the nervous system is perceiving pain regardless of whether or not there's an actual lesion in the area. But let's talk about trigger points. So in normal physiological conditions, we have a muscle contraction where the motor nerve will release acetylcholine to the synaptic cleft. This goes down the T-tubules, which then results in the release of calcium by the endoplasmic reticulum. This calcium binds to actin, which allows for the binding site of myosin binds onto troponin, which allows for a binding site of myosin onto actin, and therefore we get a contraction. This happens very quickly, and with a lot of fibers all at once, we get a summation of a contraction. Now, in order for that myosin head to release from actin, it requires ATP. And so that means we need oxygen. Without oxygen, you can't make ATP. Without ATP, you can't disassociate the myosin head from actin, and therefore you get tetany. This is why in rigor mortis, you start to see the contractions of the muscles. It's because there's no more ATP, because there's no more oxygen, and therefore the muscles start going into a permanent kind of contraction. So this isn't unlike the model of how this works within a trigger point. A trigger point theoretically occurs when there's hypoxia in the area. So there's not enough oxygen to create ATP, therefore you get this prolonged contraction, and there's just not enough ATP to bind to actin to disassociate the myosin head. So one theory about how this works is that there's this energy crisis, and that muscle fibers that aren't as big or have as much circumference, their ability to metabolize quickly enough ATP to keep this kind of function going of a contraction, relaxation, and contraction. There's just not enough ATP, and therefore there's hypoxia, and therefore there's no ATP, and the muscles kind of go into this prolonged contraction. And that may be true, for phasic muscles, or like a muscle like a bicep, or when we think of fast twitch, fast glycolytic fibers. However, slow oxidative muscles are the ones we typically see in slow twitch, or postural muscles, obviously with the paraspinal muscles, or say like the soleus. That's not how the hierarchy of muscles work. The hierarchy of muscles work within this context, or within slow twitch fibers, or kind of our postural fibers. Especially for chiropractors, this should interest us, because it's the coordination that makes up which muscles fatigue faster than others. Meaning by the time you have one muscle contract, another one will take its place, and so on and so forth, until when it comes back to that muscle fiber that had originally contracted, there needs to be a relaxation long enough for ATP to reaccumulate in the cell so that it can contract again and relax. But if there isn't enough ATP in the cell and there's discoordination, the muscle will then be acted or called upon to fire, and there just isn't enough ATP for that to happen. So you end up again in this hypoxic state. So we really can't blame the size of the muscle fiber on this energy crisis that we find, but rather a lack of coordination. So what I mean by lack of coordination is the nerves tell which muscle to fire, or which muscle fiber to fire in what order. And if the central nervous system can't coordinate which muscle to fire at the right time, that results in a muscle fiber being called upon to fire faster than its ability to replenish its stores of ATP. And therefore you get this energy crisis, or hypoxia. So it's really a neurological problem that creates an energy problem. Well, so what? So we have muscle knots. What's the big deal? Well, these muscle knots, or trigger points that we get over time, they don't contract normally anymore, because there's knots in the muscle. So when that muscle, that meat, contracts, now it doesn't do so in an even way, and it's not coordinated. And there's this thing where the muscles are attached to joints. And if the joints are pulled upon by muscles that are discoordinated, now you have micro trauma to the joint. The joint doesn't move the way it's intended to, and over time it breaks down. So in this study by Punjabi, he kind of goes further into how this accumulation of micro trauma results in the degeneration of the joint itself. Not unlike a Charcot joint, where in diabetics we find that the nervous system can't communicate between the joint and the brain, and so this discoordination between the brain can't tell the muscles how to move the joint safely, and the joint ends up completely wearing out as a result, kind of grinds itself down. So what they're saying here is that there's this accumulation of microtrauma due to discoordination, and this microtrauma over time results in the joint degenerating. Traditionally in chiropractic, we would call this subluxation degeneration, right? Something we heard. This is kind of an elegant model as to how this occurs neurologically. Now, the other thing is that as these joints degenerate, within these joints we have mechanoreceptors, right? We have GTOs in there that tell, and also mechanoreceptors within the joint capsules that tell the brain how fast and how much the joint is being stretched so it can move it safely. But because of the injury to the joint, as a result, those mechanoreceptors give bad information, or what they call corrupted signals to the brain, and now the brain doesn't have the right information to then produce more motion safely. So over time, the degeneration of the joint causes a degeneration of the mechanoreception. You get this corrupted signal, and you get this garbage in, garbage out phenomenon that's a feed-forward cycle that results in greater degradation of the joint because of the abnormal stresses placed upon it. So you can kind of think of it in terms of maybe a car, where because of a discoordination within the computer system of the car, the gears start to grind, and as a result, the sensors within the gears start telling the computer even worse information, which then causes it to grind even more, and so on and so forth. Now, the reason this happens is because there's inherently just a poor healing mechanisms within the joint, especially in the spinal ligaments. There's just not a lot of circulation. So while this microtrauma occurs all day, every day, in and out, when you go to sleep or your body tries to heal, it just isn't enough time before more microtrauma happens the subsequent days. And again, over time, this causes joint degeneration and therefore more inflammation. And with more inflammation comes pain. So while we all understand acute pain, a lot of our patients are suffering from chronic pain. It's pain that's been going on for a while. This is the kind of pain that results in sensitization. I mean, they're just more sensitive to pain in general. This is a result of plastic changes within the central nervous system that basically put in superhighways for the pain to get to the brain. And so things that maybe weren't experienced as painful at one point now become extremely painful. Hyperalgesia, this is again just something that shouldn't be as painful is just now way more painful. Think of it as your patients that you can barely touch them and they're like, ow, everywhere. It's not just in the area where they might have an injury or you think the problem may be, but that their entire body seems to be just more prone to pain. And while they may say, I have a high tolerance for pain, they may be able to get on with their day with pain, but their brain is just not equipped anymore to keep pain at bay or from their consciousness. And then they also suffer from allodynia, which is where things that shouldn't cause pain, just gentle touches or little movements that shouldn't provoke any pain, now become in and of themselves pain provocative. So when we think of chronic pain, it's not just this joint has been in pain for a long time and just always hurts. Chronic pain is a neurological phenomenon where your nervous system has all kinds of mechanisms in place to keep pain at bay from being realized. But because of the superhighways being put in to facilitate the sensation of pain, it can no longer do this. And so now just everything is pain and everything is more painful than it should be. And so now it's no longer a problem of the area of complaint, but rather a problem of a nervous system problem in processing pain. Now we've gone from a trigger point to discoordination, to joint degeneration, to pain, to chronic pain. But there's a big emotional aspect or psychological aspect to pain, whereas over time, people in chronic pain, their psychology starts to change, and it changes how they experience emotions, and it also changes how they how do they relate to their everyday life. Because their brain wants them to escape pain, they have this desire to kind of terminate being where they're at or the experience they're at any given time. They're a little more anxious, and they just want to escape anything that's going on in their life because their body just associates everything with being painful. So over time, any acute pain can become what we call central pain syndrome, or can become chronic pain. And when we're dealing with these patients, we need to realize that it's not necessarily the joint or a specific injury that's now causing their sensations of pain, but a generalized sensation of pain that's occurring independent of any given tissue within the central nervous system. We call this central pain syndrome. So it's any pain that's lasting longer than 3 months. Again, they notice that they're experiencing allodynia, hyperalgesia, and it's also these patients that you know these patients when they come in. When they do their pain chart, sometimes they're all over the place. It tends to change without any explanation. Or we can't reproduce the pain. We're trying to use our orthopedic tests and our palpation skills and everything we have, and we just can't seem to find a picture or some sort of outcome that shows this body part is the pain generator. So the symptoms of central pain can present itself as burning, even numbness, tingling, paresthesias. How many times have we had those patients and they don't have anything that's neurocompressive like a disc or degenerative arthritis that's causing stenosis at the IVF, but rather they have pain, they have tingling and numbness that's occurring without any explanation structurally. So central pain syndrome can exhibit itself as kind of paresthesias or tingling as well. It can be triggered by extreme temperatures. People with central pain syndrome typically don't like extreme cold or extreme heat. Loud sounds can even trigger the pain. And again, just think of this nervous system as resting at a delicate threshold where just anything can trigger the sensation of pain in these patients. Other names for central pain syndrome include centralized pain, central sensitization, widespread or diffuse pain, or neuropathic pain. It can also be associated with mood changes, fatigue, cognitive disturbances, sleep changes, catastrophizing, where you think, you think everything is going to be terrible all the time. These patients, they come in, they typically are a little grumpier. They're just tired. The pain has kind of just worn them down. Their ability to concentrate goes down. If you start asking them questions in their history, these are your patients that can't really answer the question. Hey, Mrs. Jones, what did you do that caused this pain? And they'll say something like, so-and-so won bingo last night, or, my son-in-law is having some legal troubles, or, they can't seem to focus on any given task. And this can be extremely frustrating, but you should understand that these patients are often behaving this way because of the pain syndrome that they're experiencing at the time. And that really has nothing to do, or less to do, it could be both, but it has less to do than any specific structural problem. So central pain syndrome occurs in people with fibromyalgia, anywhere between 5 and 15% of those cases, osteoarthritis anywhere between 10 and 40%, rheumatoid arthritis between 10 and 40%. And I think this is important because if it is an osteoarthritis, which the vast majority of our patients probably have, to think that 1 in 10 to almost half of these patients have some aspect of central pain syndrome, we have to start addressing the patient as a whole and not just as trying to find the pain generator, but realize that these people may also be experiencing a central nervous system condition in central pain syndrome. The risk factors for developing central pain syndrome is anyone who's experiencing any kind of physical trauma, if they've had any kind of infection, chronic stress. I mean, how many people are under chronic stress in our society? It's endemic, especially since COVID. Obesity, again, this is a huge problem in our society, but is also a risk factor for central pain syndrome. People who experience depression or suffer from depression are at a greater likelihood to develop central pain syndrome, or anything with like early life trauma. All these things can take what would be a normal run-of-the-mill neuromusculoskeletal injury and could throw them into central pain syndrome. It's also why we should let our patients know that sitting with pain is never a good idea. Waiting it out or trying a bunch of different things to try and reduce pain that eats up time and allows the pain to persist increase their risk for developing a more central pain syndrome kind of profile. They say that it's 50% environmental and 50% genetic, meaning 50% of people with central pain syndrome probably have it because of something that had happened to them in their life, and then 50% is just their genetics. Now, something else that we should also be aware of is that over 1/3 of women with chronic back pain suffer from centralized pain. So just think about that 1/3 of your patients that are female that suffer from chronic low back pain also have this neurological component to it that's either entirely responsible or in some part responsible for their pain profile. And so again, it's something where we want to consider not just treating the patient as far as trying to find or locate the pain generator, but we need to become effective at treating pain that's in the central nervous system itself. And how do we do that directly? Now, patients with centralized pain are also most likely to be lost in follow-up after initiating treatment. For whatever reason, and maybe because of the psychological profile of people that are suffering from centralized pain, their ability to make their appointments on a regular basis or keeping track of those patients is just more difficult. And while this can be frustrating for anybody trying to treat any kind of patient, I think chiropractors are especially in tune with this phenomenon, but we also need to understand that maybe their ability to make their appointments and stay with a treatment plan seems to be more difficult because of the condition itself, and that may be something to consider when scheduling these people, or making sure that they follow up with their appointments, or encouraging them as to why they're doing what they're doing in your office. So people suffering from central pain syndrome, they often get treated pharmacologically with antidepressants and anticonvulsants, And NSAIDs and opiates are typically not very useful. And why? Well, again, NSAIDs are reducing inflammation. Well, the problem is not inflammation. It's that their central nervous system is reducing pain or producing pain when more so than it should. And so these treatments can often be not very useful. So other medical interventions would include neuromodulators, anti-epileptics, antidepressants, and cognitive therapy. Now, I mention these because now most chiropractors are saying, well, I don't offer any of these things, and that's true. However, your patients may need them, and it's something to consider in co-management. There's a lot we can do for these patients. However, trying to fix these problems all by ourselves may often prove to be pretty frustrating a task, and so it's okay to ask for help sometimes. But they also note that some other effective treatments include traction, massage, stretching, and TENS. So I bring this up. Why are we talking about this in the context of dry needling? Well, because dry needling is something that we can use to directly impact the nervous system via mechanoreceptive dose. We can offer a lot of mechanoreception to the central nervous system in the form of electrical stimulation in the addition with needles. In fact, there's a technique called perineural needling where you place the acupuncture needles close to the nerves themselves and just provide a barrage of mechanoreceptive input into the central nervous system. Now, the thing about the central nervous system is that it's plastic. The axons will grow just kind of like vines on a wall, and just like plants in your house or vines, if you ever had them, they will grow towards where there's light. In the context of the nervous system, the nerves will grow by how much they're being used. And if you can offer something other than pain to the central nervous system, it'll try to accommodate those sensations, i.e. mechanoreception, by growing more competing afferents that carry that information. And the more it can do that, the more your body can then, or the central nervous system has ability to properly modulate pain. Also, mechanoreception isn't just delivered by the chiropractor, it's delivered by movement. So if we can provide enough relief so that the patient can engage in movement on their own, it's a perpetual source of mechanoreception, and we can take that therapeutic benefit out of your office and continue it with the patient themselves. And we can do those things with dry needling because often these patients, you can't touch them very much. They maybe can't tolerate adjustments or a lot of deep tissue therapy or certain amounts of temperature. So needles are really helpful in this case because you don't have to move the patient, and you can create a lot of therapeutic benefit for these patients that are maybe hypersensitive, or the treatments that you're trying to use are just too painful and poorly tolerated. So let's talk about whether or not chiropractors are qualified to perform dry needling and or acupuncture. Let's focus mostly on dry needling, though. There's always some conflict when it comes to scope between professions and who's kind of on so-and-so's turf. Now, within the acupuncture community, they are not too terribly pleased with chiropractors or physical therapists performing dry needling because they see it as a direct competition. And no wonder. The vast majority, as we covered, go to see them for musculoskeletal pain and pain conditions. So the last thing they want is somebody else who's in that world of treating musculoskeletal pain to have access to the same tools they have. One of the major arguments they make for why physical medicine practitioners shouldn't have access to this treatment is that there's just an inadequate amount of education. But if you look at the relative education between the typical acupuncture program and doctors of physical therapy, for example, you can see the hours for doctors of physical therapy is significantly more. And when you compare it to chiropractic, again, the chiropractic education, there just is simply more. Now, 100% of acupuncture training is not the safety and how to place needles, but also things like Chinese medicine and counseling and other subjects that really wouldn't impact the safety of the procedure. Whereas in chiropractic education, there's a whole lot of hours based on physiology, anatomy, diagnosis, and lots of other subjects that make us uniquely qualified to treat musculoskeletal patients. In fact, if the argument is that those with the greatest education in musculoskeletal conditions should be the ones able to treat using this technology, it stands to reason that we should be the ones being able to do it. And again, just to reiterate that the vast majority of acupuncture-seeking patients do so for musculoskeletal complaints. And who better to provide that relief than the musculoskeletal experts like chiropractors and physical therapists who spend the vast majority of their education on these types of conditions. So chiropractic is not stealing acupuncture by doing dry needling. Remember, dry needling is a unique therapeutic intervention that was developed in the medical community via Janet Travell and Simmons. And also, no single tool or intervention defines a healthcare profession. It's the scope of practice. And our scope of practice is largely the neuromusculoskeletal system. That's what defines us as practitioners. It's not the adjustment, it's not TENS, it's not exercise, it's not any of these things, it's the scope of practice. And we are uniquely qualified to address these issues more so than maybe anybody else in the physical medicine community if we so choose to do so. But there's also risk. So let's talk about the risk involved in these interventions and how much risk and what kinds of risks are we introducing to our patients by using these interventions. It's one thing to have something that's very effective, but we also need to be very aware on the risks involved. So here is a study where they looked over all the adverse events that occur with dry needling, and the vast majority is bleeding and bruising, which kind of makes sense. Nothing life-threatening there. Some pain during the treatment, some pain afterwards, and then there's these other far less common things such as numbness or shaking or emotional breakdown. However, I have seen an emotional breakdown as a result of dry needling. I've had a patient where I dry needled just a levator scap muscle, and the patient had immediate relief. But in that relief, there's such a catharsis or some sort of emotional tying to that pain that she immediately started crying. And I asked if she was okay, and she said, "Yes, I feel great. I don't know why I'm experiencing this." So it's a lot to be said about how pain in the background of our minds may impact our emotional well-being as well. Drowsiness is extremely common just because when you reduce the amount of nociceptive input into the central nervous system, the fight or flight response goes down, and that relief can be very cathartic, and the patient can feel just generally relaxed afterwards and sometimes a little drowsy. That's why it's important to make sure your patient is functional enough or aware enough to be able to get in their car and drive often after treatment. Now, a lot of this is common sense, right? Here's an example of acupuncture going horribly wrong, and very deep acupuncture at that. It's a case where a woman died in Korea. She was 68 years old, and somebody placed a 150 millimeter or 15 centimeter needle into her abdomen, which must have gone all the way not only through her abdomen and through her abdominal muscles, and not only that, but then pierced the duodenum and created a fistula between the duodenum and the aorta, which resulted in the blood being able to flow directly into the duodenum, and the patient then bled to death. Now, this is just a lot of poor decisions stacked on top of poor decisions that resulted in this, but it also goes to show that without proper training and maybe understanding of the human body and a deep understanding of three-dimensional anatomy, how if you have these tools, you are considerably safer, and without them, you're introducing a lot of risk to your patient. Now, not very common, but it does happen, is a phenomenon known as pneumothorax with any kind of needling intervention. It happens with injections, it happens with acupuncture, and it even happens with dry needling. And this is where you can puncture the pleura of the lung, resulting in allowing for air to get between the lung and the pleura and causing the lung to then collapse on itself. This is obviously an outcome we do not want and can be a medical emergency. Here's kind of what it looks like on a chest film, if you can appreciate that thin white line just above the fourth or fifth rib there, kind of overlapping the right clavicle. You can see the pneumothorax there. Now, most of these resolve on their own. The body heals and it reinflates. Less common, it may require some sort of medical intervention, and even lesser than that would be something like surgery. But it's important to know what the risks are, so not only you can tell the patient so they can have informed consent, but then you're also aware of when these things happen, what to do, and how to let the patient know what to do if they happen. Now, something unique to chiropractic is our access to an understanding of imaging. And I believe this is something that puts us far and above in the safer category, or could, because it allows us to actually measure the depths of tissue on our patients. Here's an example of, this is a pretty thin 20-year-old male, and you can kind of see the distances here. I drew some between the back soft tissue, how far, till we get to the central canal, the spinal canal. And then on the axial projection, you can see it's about 47 millimeters to the lamina, and at the most shallow point there, about 39 millimeters to the lungs. Now remember too, they're lying flat on their back, so these tissues are compressed. So there may be a little more depth added, but we can actually measure the depths on our patients to see where the structures we're trying to target are, which is a unique thing to our profession and could make it so we could needle not only more effectively and more targeted, but also safer. So when you're performing deeper needling techniques, it's important to know where your landmarks are. And this is where your palpation really comes in handy, because the accuracy of your palpation is very important when performing these techniques, because if you're off by just even a little bit and you're not where you think you might be, you could be placing a needle into tissues you don't want to. So in the training that we do in dry needling, we want to know exactly where things are, like, for example, the clavicle. It's safe to assume that there's probably not lung tissue above the clavicle. Now, that's good to know if you're going to needle the upper trapezius. However, in about 25% of patients, the lung apices do tend to project above the clavicle. So we want to be even extra careful of that, but we should know where these things could be. They also found that lung tissue is typically about 3.1 centimeters or 31 millimeters from the skin. So that's important to know, because then if you're going to pick or choose what needle length you're going to use, you're going to want to, if you don't have imaging, it's good to know what some safe depths would be in choosing the appropriate needle length for that intervention. They note that the riskier areas for needling and getting a pneumothorax is the upper trapezius, the lower cervical paraspinals. You could pass right past the cervical spine and go into the lung tissue there. Rhomboids especially, they're extremely thin. It's very easy to go through those, slip between the ribs and the intercostal muscles and puncture a lung. And supraspinatus. Again, that's a very common area with lots of trigger points, and it's a great place and very effective place to needle. However, it carries with it specific risks, and there are techniques that one can use to mitigate those risks as much as possible. And those are things we usually teach in our class or in any reputable dry needling instruction. Now, here's an example of neuropraxis as a result of dry needling, where the needle actually pierced the radial nerve and did so in a way that damaged it to the point where the patient could no longer perform dorsiflexion of the wrist. So the extensor wad had become largely denervated. They found that even after 1 month, the patient was no longer able, or hadn't regained the function. Now, needles puncture nerves all the time. Now, if you think in medical practice, especially in pain management, we do needle EMGs quite a bit, and the goal there is to get it in or as close to the nerve as possible. It's extremely painful, but usually doesn't create any long-lasting trauma. So in this case, there must be more to the story, and I would only assume that this dry needler may have, and again, I don't know for sure, but may have pierced the radial nerve, usually in the treatment of lateral epicondylitis, and then proceeded to perform stippling, and actually created a bunch of trauma a lot of accumulated trauma to the radial nerve. This is why it's very important also to talk to your patients and know how to interpret how they report their pain is what tissues are you in. For example, often patients will feel a burning sensation when you first place the needle. That's usually just because the needle is really proximal to, say, a cutaneous nerve ending. And that's, while uncomfortable, it's not life-threatening. But if a patient reports electrical shock sensations going into their thumb and index finger while you're doing needling, that's a pretty good indication that you're either in or too close to a nerve and should not manipulate the needle and probably move it, if not suspend the treatment altogether. Again, these are considerations that need to be that are gone over in the continuing education that's necessary to perform these treatments safely. Now, in this study, or in this case report, they're not saying, it's not a way to talk poorly of dry needling. It says, look, these complications are relatively rare, and that if patients would just be more familiar with the relevant anatomy that they're treating, they could dramatically reduce the risk. And while we all had anatomy and physiology in our training chiropractic school, dry needling just carries with it greater risk and a more detailed understanding of the area needs to be had prior to undertaking these kinds of procedures. And it's actually a fun refresher. What you may have thought you knew about where every little muscle, nerve, and joint were via your palpation skills. When you're dry needling, the refresher actually gives you a much deeper understanding of the three-dimensional anatomy. Again, in another study, or not study, but in acupuncture, they say the same thing. If practitioners just had better anatomical knowledge and applied that anatomical knowledge, they would be able to avoid these types of adverse events and incurring risk to their patients. And again, other things that need to be taken into consideration when adding dry needling to your practice is informed consent. It may be one thing to have someone sign a informed consent, but with specific interventions with dry needling, each one carries with it its own type of risk. And these things need to be not only documented, but verbally explained to the patient as well. And you should know what those are. You should also know what to do in the event of if and when these things happen in your office. If a patient, if you have a patient who has epilepsy and has a seizure, what do you do? What if a needle gets stuck? What if a needle gets broken off in the skin and you can't find it anymore? And how do you find it? How do you get it to come out? What happens if your staff reports that they have a needle stick injury from one of the patients? What are your responsibilities as not only the superior, but also the business owner in that situation to your staff and the patient of notifying them or of what's the next steps? You should know all of these things before introducing this or any needling technique. You should also be aware of all the effective bloodborne diseases and how to mitigate the transmission of those. What the risks are, what patients and what kinds of patients who have certain type of bloodborne diseases do you want to needle or avoid needling altogether? Also, for example, can you needle someone who's pregnant? What if somebody has osteoporosis? What more risk is there in that? For example, you're going to needle somewhere on the skull or the tissue of the fascia on the skull. Well, this person's osteoporotic. How well is the bone protecting the brain from that needle? Or say a scapula protecting the needle from the lungs, and so on and so forth. People who are immunocompromised. There are a lot of things that can go wrong without proper training and also knowing which patients carry which risks. And it's important to undergo the education necessary to, again, provide the service to your patients and also protect yourself and your staff as well. So let's go over some cases here where we utilize dry needling. This example is a man who walked into my office with Bell's palsy. He'd had it for about 2 years, and he asked if there's anything I could do. Now, he'd tried many other interventions unsuccessfully, and he really could only smile on the one side of his face. So really we created this, or I created this intervention based on my knowledge of anatomy and physiology. I knew that his brain can't communicate with his facial muscles on the side of his face due to some sort of traumatic impact or trauma to the nerve. Something was impeding the signals from the brain to the muscle itself. So I figured, why not bypass the brain and stimulate the muscle directly using dry needling? So we have mimetic muscles, or facial expression muscles. And in this case, I targeted the zygomaticus major and minor muscles. Those are your smile muscles. And then any other muscles that I saw that weren't responding to when he would try to undergo some sort of facial expression. So in this case, it was also the frontalis. And by stimulating that muscle, what we found was that he started to regain his ability to smile in very short order. It was about a couple weeks. And he had significant improvement in his ability to make facial expressions on that side of his face. Now, how did this happen? Well, there's not maybe enough data on this intervention and its efficacy with Bell's palsy to know for sure. But what we do know is that when a muscle fatigues, it releases growth factors that kind of call for the nerves to re-innervate them. So when you go to the gym and you fatigue out, we know that you release these neurotrophic factors that kind of call to the nerves like vines to grow and innervate the muscles. And using that knowledge, we had a successful intervention with this patient, and he regained a very significant function in his life. Now, also on this list, and I don't have any pictures for this, but is post-surgical lateral thigh hypoesthesia. So we'll have patients who have what we call neuralgia paresthetica. That's where your patients come in, they kind of have a hypoesthesia or numbness on the lateral thigh. This is usually due to some sort of insult to the lateral femoral cutaneous nerve. This can happen. It happens a lot in our pregnant population because of the pressure of the abdomen against the nerve, kind of placing the nerve between it and the inguinal ligament. We see it with people who are hikers or runners. Again, it's probably the hypertrophy or the mechanical irritation of the quads against the lateral femoral cutaneous nerve and the inguinal ligament. That can happen as well. I see it in car accident cases all the time, where the seatbelt creates a kind of a neuropraxis to the nerve and causes this vague hypoesthesia to the thigh. There's lots of people who suffer from this, and again, it's the brain can't send an impulse from itself to the affected tissue, or in this case, the lateral thigh. And we know that as nerves, if they can't fire, so everything beyond that insult or beyond that lesion then is not getting fired, and therefore those nerves start to kind of wither or degenerate. And so we can fire those nerves and keep them healthy as things regrow by stimulating the nerves themselves, by bypassing the brain, by placing needles close to those nerves, and then using stimulation to stimulate those nerves outside of the brain so they stay healthy while the nerves re-innervate and while that lesion heals. There's some studies where they actually experimentally create lesions to the sciatic nerve and show that needling with stimulation helps to regenerate the nerve in a relatively short order, and we go over those in our classes. This was another case of Bell's palsy, where luckily this patient took very detailed a diary of her condition. Same thing with spontaneous, no real known cause. The result, was that she couldn't make facial expressions, but also she couldn't smile, appropriately, so she wasn't conveying the way she felt on the inside to everyone on the outside. She also couldn't drink from a straw. She couldn't sleep at night without a cup or some sort of tape to tape her eyelid down. And so that's a huge impact on someone's life, and that had been going on for 2 years. And she came into our pain management clinic. There she received a trigger point injection because with this facial paralysis came spasms in her face, cramping, and it was extremely painful. And they noticed that after the trigger point injection, that was pretty successful. It reduced her pain she reported a 7 to 8 out of 10 to a 4. So then we started dry needling and acupuncture in the chiropractic aspect of the pain management clinic, or my office. Getting into a trigger point injection is relatively difficult and more costly than getting into to see your typical chiropractor for dry needling. It's just way more convenient. And again, we didn't carry any risks of the risks that come with the medication. While those are small, it's still something, not nothing. And after the first treatment, she noted an instant softening of her face, zero pain, and that she started to kind of get a real smile back. And we did the same thing we did is with the previous patient, where I had them make facial expressions, see which muscles were firing and which ones weren't, and we needled those. In this case, we focused on, again, the frontalis and the zygomaticus muscles, as well as the orbicularis oris muscle, and kind of stimmed and needled those a couple times a week. Now, I also sent her to physical therapy. Now, why would I do that? Well, because what can be beneficial for these patients is not just the needling and the stim, but also the exercises that go with this. And in a typical chiropractic setting, we simply don't have the time or the resources to dedicate to sitting with one patient for a half hour or 45 minutes to perform the specific exercises that are found to be beneficial in these cases. And in her case, it was saying certain words expressively. So she had a list of words that she would say in therapy, specifically designed to exercise the muscles in the face that we were targeting. And so this, again, she's noticing that her face is looking more symmetrical. The tone and the muscles is more the same. Her movement isn't painful anymore. So this is just showing the progression and the improvement over time of the body healing itself. So we're now in 2 months of treatment, and her face is looking even more symmetrical. She no longer needs to tape her eye shut at night. She can drink from a cup, and her face isn't fatiguing as much, and there's definitely no spasms and no pain. So, we treated a specific condition directly, but the overall health of the patient was improved as well. This is, the kind of outcome that I think we all want in our practice, and it's really nice to be able to help people when there really isn't much alternative. I love the fact that we're chiropractors, and a lot of times we get the cases that everyone else has given up hope on, and we're able to do something special for our patients. And I think, the addition of dry needling just opens up a whole nother world, another tool in your toolbox to help people with even more conditions. This is a case of chondromalacia patella. I was treating it directly, so I was placing the needles just under the patella to stimulate circulation to the area, and then also stimulating the VMO, or vastus medialis oblique fibers. Now, with more education and more information, I found an even better way to treat this, and that was from that article we talked about before, where if we targeted the muscles causing the movement pattern problems that result in the tracking issues of the patella, we can better address the patella directly or indirectly. And so as a result, now in treating this condition, typically I'll take long needles, usually about 100 millimeters, and we place them along the length of the glute medius fiber or glute medius muscle. And what we were able to do then is stim the muscle, so it not only are we increasing circulation by perforating the muscle, but we're also stimulating it for more great. So think of it as a heart, as the muscle is pumping while these needles are in there, while blood is flowing to it, and you're just getting a lot of nutrition in the muscle and bringing it back online. And it's also typically painful, the muscle itself. So by doing so, the pain is reduced. You're getting a lot of reduction in a lot of the pro-inflammatory cytokines, interleukin-6, calcitonin gene-related peptide, substance P, all these things. And the muscle now is less painful, and as a result can undergo exercise and kind of perpetuate that therapeutic benefit. And by stabilizing the hip and the spine via the quadratus lumborum, we're able to kind of perpetuate that healing mechanism and address the root cause of the patellar tracking phenomenon. Now we'll also integrate taping to kind of support the patella during this healing. By keeping it in its track, I use leukotape and some other kind of elastic type taping techniques. So I want to talk about all that because it's a way to integrate what we already do. So if we thought about it in terms of your typical patient visit, this patient has a patellar tracking problem as a result of weak or dysfunctional, like lateral chain, kinetic chain. So the muscles involved are the quadratus lumborum and the glute medius. So this patient walks in, we can needle those areas, so now they have all the metabolism they need, and those muscles are functioning at a much better capacity. We can adjust the lumbar spine to address the quadratus lumborum, and then we can follow up with exercises that reinforce the stability and strength of those muscles overall. And that would be an example of a multimodal approach that really only a chiropractor could do, that's highly effective for some of these conditions. Here's an example of somebody who was in a motor vehicle accident. They had a contusion as a result of hitting their shin on the on the dashboard of the car, resulted in quite a bit of bruising there. And so using what we know about needling and its increase in angiogenesis and circulation, we used an assortment of acupuncture needles superficially to bring the circulation more to the surface into the lymphatic system, integrated cupping in order to draw the circulation up and away from the area and closer to the heart. And we also used some kinesio tape to kind of break up any of the coagulation that had happened in the area. So this is something where you might not see something like this in your typical chiropractic setting, but working in a pain management clinic or working with car accident patients, you kind of get a lot of stuff. And again, this goes way beyond what we would typically do in a chiropractic office, but with dry needling and integrating it with these other techniques, there's a lot more we could do with a lot more types of conditions that walk in our office. So here's an example of somebody with post-surgical low back pain. Now, with post-surgical patients, it's often difficult with hardware to address it. Why? Because all of our interventions rely on motion. And if there's no motion, how do we reduce pain? Well, suppose you could use stim pads, but again, we talked about dose. Well, how much dose is there in stim pads when you're just stimulating the mechanoreceptors within the dermis, or maybe it's the superficial musculature? In this case, these needles go all the way down to the lamina. So we know we're not only getting the thoracolumbar fascia, it's going into the paraspinal muscles and also the multifidi. So we're getting all of that mechanoreception, and we're able to send stim all the way down to the deep depths of those things, down to what's probably the pain generators in this case, which is the joint capsule itself. And just to increase afferentation via mechanoreception, we also targeted what are called the cluneal nerves, like we talked about before, or acupuncture point Yao Yan, and just we want to create that barrage of mechanoreception. If you think about it in terms of kind of like the Care Bear stare, if you ever remember the Care Bear stare back in the day, the Care Bears would lift up their shirt, and then their powers that be would culminate, and they would fight kind of like this laser beam of care would fight whatever evil thing they were fighting, and then they would overcome it. And that's kind of what we're trying to do with pain here, is that nociception has built its superhighways in the chronic pain patient, and we want to build collateral or competing mechanoreceptive pathways as well. And this is one of the ways we can do that with dry needling, by targeting these deeper structures. It's just a lot more mechanoreceptive dose that we otherwise would not be able to achieve with any of our other interventions, especially anything that involved motion. Here's a close-up view of a basic low back pain setup. Again, those needles are going down into the paraspinal muscles, so we're not just stimming the superficial muscles, but the deep muscles as well. This is maybe the first time ever you can directly touch and affect a multifidus in chiropractic. If you think about it, those muscles are going all the way down to the multifidus, which make up the posterior half of the facet joint capsule. And if that facet has inflammation, and now we know that multifidus is contracting over and over again, it's pumping that inflammation from the area. It's introducing new blood and new nutrients to the area so it can heal. If there's muscle spasms, we're also fatiguing the muscle. And this is let's talk about, again, an intervention where we're going to use a multimodal approach. So this patient comes in, they have pain, they can't move. Let's say they can't bend over, they can't touch their toes. Lumbar flexion is the function that they are failing to achieve. Well, we can relax those muscles and reduce the pain dramatically by performing this intervention first. And then once we do that and the patient's got a better or more pain-free range of motion, this patient becomes a lot easier to adjust, right? There's not as much muscle guarding. You've reduced a lot of the pain and inflammation in the area so that the adjustment's much better tolerated. And then if you're going to put this patient, say, on decompression therapy, it's not dealing with nearly as much muscle guarding, and the pull can get down to that joint level much more effectively. So it's all about thinking about what physiological impact you want to make and what order you would do these things in. I always try to stick to no more than 3 things per visit because it's easier to throw everything but the kitchen sink at these things. But if you start thinking of it in an elegant way of what is the process we are trying to address? Is this what we call nociceptive pain? Or is this the centralized pain? Okay, well, if it's nociceptive pain and it's actually being caused by a pain generator and not the central nervous system, then we can address it directly. And that lets us know, okay, we're going to do so by increasing circulation to reduce local inflammation, and we're going to use electrostimulation to reduce the perception of pain and spasm. Then, now that we have that window of relief, that's a much better time to introduce the adjustment, and then post-adjustment decompression and or exercises. So there's a logic behind when and how we apply these things, and dry needling really makes you refocus and become a much more focused practitioner on the interventions that you choose and what order you put them in. So here's an example of some of the training in doing dry needling. So we want to be very accurate with our palpation, and as we know, that is problematic. In chiropractic, we know that we think we know where we're at, but ultimately we're not always 100% where we're supposed to be. And it's understandable if you got an MRI and you measured the depth between the skin and the bones in the spine, you can see there's quite a lot of tissue and meat. It's almost like trying to palpate a marble through two stakes or something like that. So some of these skills, like our palpation, need some refining. And in that case, this is a setup of showing where the safe zones are and where the most likely place to place a needle to hit your target tissue would be. And in that case, we wanted to feel it bottom out or actually touch the lamina, so we know we're on bone. That means we know we've gone through all the layers of tissue, and that needle is now integrated with or as close to the pain generator as possible. And this is a great time then to integrate stim. So this is what the training for these kinds of interventions look like, and it allows us to then use these interventions more safely with our patients or introduce less risk. So here's an example of one of my students doing the same thing. Now, just like our adjusting skills, dry needling skills require time and practice. But I was very impressed with how confidently she was able to perform this technique after just getting a quick example. And so, you'll find that, and as you should be, careful and slow when you first start out. But she did a great job there, putting it in the right, palpating the right locations and finding the accurate place to place the needle. Now, this is one of my students who I revised against doing this. You should never move with needles in your muscles, just because it's going to create a lot of trauma and you're going to be very sore afterwards. But he insisted. So I wanted to show this just to show, these needles are deep within the extensor wad there, and you can kind of see when he moves his wrist how that muscle contracts. You can almost see like an outward kind of expression of the muscle contracting itself and how it kind of, the torsion of it. It was very interesting to me. It's also interesting when you're putting these needles in down to the bone, you'll kind of see or appreciate the lordotic curve of the spine when you do so. So there's some really neat, just a deeper appreciation for the anatomy that you're treating and what you kind of like what your hands as eyes get to feel when using dry needling in these interventions. So here's an example of a pretty typical setup for piriformis syndrome. These are your glute tendonitis people. This is how we reverse engineered so in pain management, we do sciatic nerve blocks quite a bit, and so there's a way to target the sciatic nerve, and so where pain management specialists are attempting to get the needle in or as close to the sciatic nerve as possible using something called Labatt's technique, we're going to use the same techniques in this case to avoid it. So we find it, we locate it, and that kind of tells us where is a better place to stick a needle to get what we want, which is to pierce the piriformis, but also avoid the sciatic nerve. We also use something called a depth check, meaning we want to make sure that we do place the needle at a depth as safely as possible and only as deep as necessary. And so we're using one needle here over the sacrum to get the depth of the sacrum, and then using a subsequent needle to then go just past the thickness of the sacrum into what is most likely the piriformis. So it's an elegant way of finding it. We're also placing needles at the greater trochanter, because a lot of times you get glute tendonitis, and this can help with the circulation of that area. There's these facets within the greater trochanter that require circulation, have a lot of inflammation, and you can increase the circulation there as well, creating a lot of alleviating a lot of discomfort for the patient. And we also are targeting glute medius as well. So a lot going on there, but affecting an entire complex very elegant, specifically and elegantly, in a way that I just don't know of any other technique that can accomplish this. So I want to thank you for participating in watching this. I hope you come away with it. Whether you choose to introduce dry needling or not in your practice, I hope that this helps you make that decision of whether you want to undertake that responsibility. Again, it's not impossible, but it does need to be taken into consideration the safety impacts, not only to your patients, but you yourself as the doctor and your staff when taking new techniques like needling into your office. You're dealing with bodily fluids largely for the first time in your profession, and this requires a whole host of responsibility, considerations, and mitigation of risk that needs to be taken into account. But that being said, it is extremely rewarding. It's very fulfilling. It makes you, I believe, a better doctor. Just kind of reviewing the systems and being having more intention in the way you practice and thinking about the anatomy and physiology you want to affect, rather than maybe going along with some sort of like a cookbook approach to treatment or one size fits all. I think dry needling kind of forces you to expand and be more specific as a doctor. Also, if nothing else, I want you to take away from this presentation the difference between nociceptive pain and central pain syndromes, and that a lot of your patients are experiencing pain that is neurological in origin or neuropathic, and that these people desperately need you to take into consideration neurological treatments when addressing their condition, and not just trying to find the pain generator locally. That these patients need a full body approach, and not just a multimodal approach or a combination of techniques, but also a multidisciplinary approach, oftentimes where they're going to need things like counseling and maybe some pain management. And that's totally okay, because you can't be expected as one physician to be one thing to all patients. And as they say, teamwork makes the dream work. So again, I want to thank you. My name is Dr. Aaron Wiegand. If you have any questions about dry needling or anything at all, feel free to email us at info@chironeedle.com. And I just want to, again, thank you so much for taking the time with me to learn a little bit more about something new that's really going to be everywhere in the pain management community and musculoskeletal community. If it isn't now in your neighborhood, it will be, and your patients will be getting dry needling, and I just think they should get it from you. Have a good rest of the day, everyone. Thank you.